Thank you very much, and wonderful to see everybody here today and so many people developing an interest in the management. So yes, I move now across to the therapy side of things, having heard, I think, a bit more in depth about some of the diagnostic criteria and the various other sort of coexisting conditions or comorbidities. My role is a physiotherapist, and I work primarily clinically in the hypermobility unit at the Hospital St John and St Elizabeth, and in my other role I'm an academic at University College London in the Institute of Child Health. And today I want to just share with you an approach, I would say an approach to rehabilitation for people with PoTS. And I suppose the other side of that, there will be a predominance towards those who have got some kind of underlying hypermobility, be it a spectrum disorder or Ehlers-Danlos. Integrating some of the PoTS-related research in exercise, of which there's not very much, but there is something to help inform what we're doing now, our anecdotal experience, and I've got a couple of case studies to help illustrate the approach. I'm going to acknowledge right at the beginning the patients who are teaching us every day how to help manage this condition. They come, as Nick said, in many different presentations, and so each one presents a challenge. Dr. Nellie Ninnis has been someone I work very closely with, not here today, but I know she's also worked with Phil Fisher and Nick Gall and the rest of our team, and I think together we came up with an approach to handling and managing some of our more complex adolescent young people. And the rest of the team who works with us in the unit. Towards the bottom there, Inge de Vandel, who has been part of an international consortium and also helped us to start to write some guidelines for exercise rehabilitation as part of the UK PoTS guideline, along with David Lowe and Professor Peter Rowe. So my interest in this area, the more complex side, I suppose, with the PoTS was about 5 or 6 years ago when we started to get more complex patients presenting to our unit. The first thing was that this underlying joint laxity, the hypermobility, the joint instability, which we'd now understand as possibly being hypermobile EDS or a hypermobility spectrum disorder. Alongside that, I suppose the next thing to say was the persistent pain, persistent fatigue, and then this kind of pre-syncope, sometimes fainting, temperature dysregulation, the gastrointestinal symptoms, bladder, and these kind of allergies and rashes, what we seem to be thinking is some kind of mast cell activation. And the onset, and this is a slide that I've taken from Nellie, that we have some people that are kind of sliding into this condition over a period of time, often through adolescence with hormonal onset and some of the physiological changes, and others sort of falling off a precipice after an injury or a marked illness, who would develop their hypermobility symptoms may start to develop, but also their PoTS and dysautonomia. So together we kind of came up with this kind of model to help us look multisystemically at how we'd manage our patients, because it is a holistic approach, and I think we've already heard that this morning. We have to tackle it from a number of different angles. So we kind of came up with these kind of spokes, and it helped us to explain to patients, and it helped us to understand ourselves. Now, we've not validated this scale. It's at the moment, it's a scale that helps us to understand, but we are in the process of trying to work towards validation, and we might get some patients who are more on the fatigue end, perhaps with a cardiac dysautonomia. There may be some mental health issues around anxiety, depression, and we might start to tackle each one of those different spokes. Others may have more musculoskeletal symptoms, so you can see the shapes of the patients presented to you, and you can plan your way through the management. And some, the most complex, having this whole big complex spectrum presented to us. And as many of you will know who are working with these clients, is how to, they're often looking for answers, looking for more diagnoses, looking to understand. And I spent quite a bit of time in Nellie's clinic where she would say to people, you can either come and look into this grey door and we can keep on exploring these problems, or you can come to the blue door and start looking for some solutions. So we've taken a problem-based approach, exploring the expectations with the patient and trying to help them move towards the blue door, which is about starting to manage their symptoms as we start to understand more the complexities. So they've got the choice. And then I suppose in terms of the rehabilitation principles as a therapist and part of the therapy team, I felt my role and the colleagues that I work with, our role is then to start to reassure, to start to think, actually, this isn't a heart attack. These chest pains that you're having, this tachycardia is not going to lead to death. And they've heard that, might have heard it from their cardiologist, but then to be able to reassure those kind of things that they might be worrying about. We have to start to think about pacing, because there's often these kind of boom and busts on, as you'll know, with these dysautonomias, or whether you're working with chronic patients, they'll often have these fluctuating symptoms, and on a good day they'll do a lot and too much, and then they'll drop down into a bad cycle. So part of our role is to help to kind of pace, to agree and set some kind of realistic goal, I think is quite helpful, because otherwise they're, as I said, tipping and turning with each turn of their dysautonomia and their pain. Some kind of cognitive behaviour approach. We have some psychologists that we work with, but of course that's not going to be available to all people. So I think we've had to learn some of those cognitive behaviour approaches ourselves to help people move forward. And that might involve some relaxation training as well, mindfulness. We have a medical hypnotist that we sometimes use as well with really complex patients who find it hard to penetrate with talking therapies. The hyperventilation Nick talked about often coinciding with the anxiety, which may be physiologically driven or psychologically driven. So breathing exercises, very, very helpful. Sleep management, because fatigue is often playing such a big part, actually helping people to sleep better through sleep routines, timing of food, because if they're eating very late or exercising very, very late, then that can actually trigger a tachycardia. Screen time, so there's a number of things, darkened rooms. So we've got a range of different ways that we start to manage sleep. And more recently I've been using the Sleepio app, which is an app that's been developed at Oxford University, very helpful, which gives very good feedback to people. So the Sleepio app's quite good for those who have got sleeping problems. And then, we're not prescribing the medications, but we're often there to be able to help monitor and to ensure that those medications are taken, because for a lot of people, they don't not necessarily complying, but we can help to ensure that. And often those medications can be very complex if you're dealing with all those different, axes on that scale I showed you. And then further advice on the non-pharmacological treatment, which has already been highlighted, but I think we're there to reassure and sometimes to also reinforce the dietary advice that's been given. But our main role will be to design and implement some kind of functional rehabilitation program. And in that, it's usually along the lines of some kind of reconditioning. And there is evidence to suggest that orthostatic intolerance and PoTS are related to deconditioning. We don't know whether it's the cause. We don't know necessarily whether it's the effect. But the reality is there is a relationship, and deconditioning negatively influences cardiovascular function. So we need to be dealing with and improving exercise tolerance on the premise that long-term benefits of physical fitness will counter orthostatic intolerance, increasing blood volume, increasing cardiac output, enhancing vascular compression, improving the endothelial function, and also improving the baroreflex. So there's good reason to exercise, and as physiotherapists, I think that's one of the main reasons why we become therapists, because we think we can impact and make a difference. Nick already showed you this particular study, but it's one of the ones that helps to underpin that exercise can be helpful. It's one of the only well-controlled studies that have been done. And it showed after 3 months that 10 out of 19 cases no longer would have met the diagnosis of PoTS, and there was a significant reduction in upright heart rate and improved quality of life. When you read deeper into this paper, what you'll see is in the exclusion criteria that those with hypermobility or EDS were excluded. So I kind of put this to one side and thought, well, there's something helpful here, but the population that I'm often dealing with has been excluded. So moving along in the literature a little bit further, the same team also did a study that looked at a beta blocker versus exercise, and helpfully, I suppose, has shown us that potentially exercise could even have a better role than beta blockers in some circumstances, but again, the hypermobile EDS population isn't in that, it's been excluded. But there are side effects of medications, and often patients don't feel comfortable taking those medications, and therefore, again, exercises, we've got some good support to suggest exercise will be helpful, because the beta blockers, as we've heard, can cause fatigue, the fludrocortisone can cause hyperkalemia, and we've got others that can cause hypertension. So in terms of planning a rehabilitation program, based on the evidence that's around at the moment, is we're trying to improve cardiovascular fitness. We want a better stroke volume, and we want all those improvements that we've seen. And generally, we will focus our attention to the lower limbs in terms of managing the PoTS symptoms to try and get an improved vascular return. So it might be that we start with chair pedals, it might be a reclining bike. Generally, we'll start in some kind of recumbent position unless our patients can tolerate the upright. And that's really because the stroke volume response to exercise is reduced, and so people feel quite dizzy often when they're exercising. So they're going to feel more comfortable when they're in this recumbent position while we start to improve their fitness and then take them gradually up. The other side of the program will be to look at resistance training or strength training. We might be using body weight, we might be using weights, we might be using elastic bands. But just to take care here is that when you start applying resistance training, it does put more stress on the cardiovascular system, and then you can start to see issues with blood pressure, particularly if people are doing a Valsalva and actually they'll have an increased blood pressure, and then sometimes you'll get this drop in blood pressure as well. So we're very careful how we grade our resistance training. Now, there has a paper came out quite recently, this study by George et al., again showing us, actually gave us the intervention as well that might be useful for managing people with PoTS. And it's quite very nicely showing that in the first month you do 3 to 4 sessions, you can work on resistance training once a week, and I've kind of color-coded this because they've talked about using a rate of perceived exertion to tell us how hard, how intense we can be working. And in the second month you can move people into the upright, and in the third month you can start running and going to a higher intensity and increase your resistance training, and by the end of the 3 months everyone's going to be feeling a lot better. Now that might be the case, and I have seen some patients who do very well with this when they haven't got all those other complicating problems. If it's a straight PoTS patient, which there are very few of, but when they've got underlying hypermobility and chronic pain and sleep disturbance, actually this program, to be honest, I haven't been able to achieve this kind of outcome. So my reality, and probably the reality of the other therapists in the room, would start to look more like, in the first month we might be doing 4 to 5 sessions of exercise, but it's likely to be somewhere between 2 and 10 minutes of cardiovascular, working at a very low rate of perceived exertion. And because of the underlying hypermobility, we will be doing some strength work, perhaps what we call motor control work, some proprioceptive work to start to deal with the underlying instabilities. And then we'll start in the second and third month to be able to start to move people potentially up into the upright, some more functional approaches. And then in the 4th to 6th month, we're starting to get somewhere where we need to be. And we've now got some research evidence that's coming out of Imperial in the hypermobility world to show us that actually our patients who have underlying hypermobility syndrome are very, very much weaker than others, and because they're starting from a different place. So that's why it takes so much longer, I think, to take these more complex patients through. So the top tips, this is my last slide, I think give hope would be one of the things when you're seeing a lot of these complex cases. The holistic approach we've started to hear about already, tackling the problems in a team. Finding a baseline is very important in terms of the therapies, progressing steadily, obviously with the drinking before and after when we're exercising to the therapist. Psychological support is going to be useful in some way through our own training or hopefully through the help of others. Graduate slowly, and if they've got an underlying hypermobility issue, then you need to tackle that as well. So we need to incorporate that into the exercise training. So that's my talk. Thank you very much for listening, and I've got some questions later on.